Greetings and welcome to today's webinar. My name is Alaina Kennedy and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, commonly referred to as IAMHP. Before we dive into our conversation today, I'm going to take a moment to walk through the platform a little bit more. As you can see, IAMHP utilizes the GoToWebinar platform. A control panel should have popped up on the right-hand side of your computer. This is your window into interacting with the presentation today. So let's take a moment to dive into it a little bit further. At this point, all of you should be able to hear me either through your computer or phone. Please note, if you are disconnected from your computer or phone audio at any point, don't worry, you can move between the two different platforms at any point. If you need to contact me about audio, you can direct those via the questions tab. In addition to directing audio questions via the questions tab, you can also direct questions related to today's presentation. I'll be answering those as we move along, but I'll also be holding a few of those towards the end for our Q&A section. Please note that we will not be unmuting the line, so should you have a question, please submit those as we move along so that we can get those asked and directed towards our panelists. Don't worry about webcams or polls, we won't be utilizing those today. However, we will be utilizing our chat function. As things come along, I might input information in the chat function for all of you, or links and helpful hints and things like that. You can also chat amongst the other attendees today or with myself. I'm coming up as IAMHP admin or IAMHP organizer on your end. I do want to note, though, that due to some provider organizations and Medicaid health plans firewalls, they are not able to access the chat function. Our apologies for that inconvenience, and we appreciate your understanding. Additionally, we've noticed that due to the version of GoToWebinar you have, you might not also be able to access the chat function. And we just encourage before our next Lunch and Learn or complimentary webinar, that you download the most up-to-date version of GoToWebinar. Great, with the logistics out of the way, let's get us diving into why we're all here today. So as noted, my name is Alaina Kennedy, and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, and I'm so excited to be joined by CountyCare here to talk about housing and healthcare. I think this organization and Medicaid Managed Care Plan is so innovative in all that they do and really are on the cusp of addressing the social determinants of health. And I definitely think this is one area where they are just really moving the needle, and I'm so excited for them to just talk through their experience, some of the challenges, the opportunities, and just how they've been leading the way on this. As all of you know, the impact of housing on health is being widely considered by policymakers and industry leaders across the country, not just here in Illinois, as housing is now one of the best researched social determinants of health. And we're seeing that by addressing housing for low-income individuals or those who are housing insecure, we can have an intervention on the health outcomes and decrease the healthcare cost. And so as a result, many healthcare systems, payers, government entities are seeking to better understand how housing and health intersect, and to review the literature and the information on this and how we can all do this effectively. And so I think that CountyCare is just, as I noted, fantastic for this and are really going to help us walk through some of that a little bit further today. So without further ado, I'm going to hand it over to the Chief Medical Officer at CountyCare, Dr. Collins. Dr. Collins, welcome.
Thank you, Alaina, very much for the invitation. I'd like to thank the audience for joining us today. CountyCare wholeheartedly believes that housing plays a significant impact on the health outcomes of our members. The list shows us that those experiencing homelessness have higher episodes of high blood pressure, diabetes, various lung diseases, HIV, substance use disorder, and mental illness, to name a few. as Alaina started to talk about, the literature also shows us is that if you intervene and break that cycle of persistent utilization within the healthcare system, you can decrease the amount of funds that are spent on ER visits, hospitalizations around this particular set of members. So we that as we talk about healthcare, we have to talk about housing. And so I ask you, when we see patients and members, very commonly they're given a prescription for their high blood pressure or their diabetes. We've seen prescriptions given for exercise. And so we as a health plan think it's important now that we talk about a prescription for housing. Our members need safe, stable, permanent housing. And today our objectives are really to talk about our strategic direction in terms of how we support our members experiencing homelessness, and really looking at how we look at that as part of a racial equity framework. Because I think we all know that the problem is not that the Blacks are not housed or the Hispanics are not housed, is that housing in and of itself and the disparity there is related to racism. We'll also look at how our participants understand the data that we use to target how we will house those that are experiencing homelessness, and look at the role that care management plays as we've worked with both the Chicago and the Cook County Flexible Housing Pool. And lastly, but probably at the center of all of our initiatives and work around housing is really the critical role that street outreach and home-based services, especially behavioral health services, play for our members who experience homelessness. And so I'm going to move out of the way and let our presenters sort of take it away. We have Betsy today, who's the CEO of Higher Ground, Jessica, who's an interim program manager with CountyCare, and Michael, who's with Renaissance. And I think these three components will allow us to take a deeper dive into the importance of housing. Betsy, I'll turn it over to you.
Thank you. I'm happy to be with you all today. Betsy Benito with High Ground Partners. So as we think of, as from the health perspective and wanting to address health outcomes and reduce disparities in health outcomes between different categories and different populations and subpopulations of people, I think we have to understand that we're walking into racial disparities that are here by design through historical racist practices and policies that have really set up how making the connection between kind of population and location. And so when we think of where people can live and what we think around home, we have to really look at the history of housing policies, which have by design been to keep African Americans excluded from access to wealth, access to health, access to education. And so we will see that in the data that is forthcoming. So this particular study, while it's outdated in terms of it's a 20-year-old report, really is at the time probably forward thinking of setting the stage for a racial equity approach and response, and to really fill in the understanding at the time of the connection between health and wealth. And so really an understanding back in the early 2000s of people that have greater access to resources have higher health outcomes, but really filling in the gaps in this particular report of things that we now have a much deeper understanding of that connection. I think one of the key, just not to spend, I don't want to give it short shrift, but I do want to really give the framework that within housing policy in the US, their quote is, it was imposed by legislation, supported by major economic institutions, enshrined in housing policies, and enforced by the judicial system and legitimized by the ideology of white supremacy. So when we think of a lot of what we're trying to unpack within the housing space and then within the housing and health space, really has to do with shifting away from exclusionary policies and restricted housing covenants toward inclusionary zoning, pushing for deeper investments in communities that have been stripped of investments and intentionally red line to have preventative lending and to really be forward thinking. So I have sent along the link to this particular report, and I have also sent along links to other entities that are really looking at solutions from the housing and community development end. Metropolitan Planning Council has issued a cost of segregation report and follow-on policies that are being pursued and in many ways being adopted through the city of Chicago and in the region, including Cook County government. So we need to make sure that as health is moving forward to close racial health gaps, that we understand that we need consistent policies that support the same goals. You can go on to the next slide. So when we think of policies that have created significant racial disparities in terms of housing and health outcomes, this is really exacerbated when we consider kind of these extreme conditions, including homelessness. In Chicago, over 80% of people experiencing literal homelessness are African American, and this shows up in the lives of children, both in literal homelessness as well as in our Chicago public school system, of really this major impact of homelessness and housing instability among our children. You can go to the next slide. So when we think of the health gap and health disparity, it also shows up in mortality. So this particular report, I think, is a good example of replicable information that we could look into in Chicago and in Cook County and across the state of Illinois. But in Los Angeles, essentially, in looking at a much lower average lifespan and really a higher mortality rate, looking at people experiencing homelessness, the top 5 reasons for death and mortality in LA are drug overdoses, coronary heart disease, transportation-related deaths, homicide, and suicide. And within these, it's impacting people at at much younger ages, including heart disease, much younger deaths, with really much higher rates. Drug overdoses are 36 times higher in people experiencing homelessness than in the general population. And within all of these, while whites are at a higher number or a higher rate, those rates have been holding steady, while among the Black and Latinx population, the death rates for these reasons have been increasing in the past couple of years. As a result, they really created a homelessness mortality prevention initiative, and they're outlining a lot of strategies and working collectively across systems, and some areas in particular of linking substance use treatment locations and stable housing, whether that's an interim housing or whether that's linking directly into post-treatment housing, more culturally appropriate outreach and other policy initiatives. And so really wanting to really understand and how to address mortality among this particular group. You can go to the next slide. So in follow-on, this is what it feels like, and this is what it looks like when we talk about racial disparity in people experiencing literal homelessness. And so, you know, while these charts are very jarring, that in Chicago, 30% of the population are African American and 80% of the homeless population. You know, it's just as jarring in a city like Los Angeles, where under 10% of the population is Black and nearly 4 times that are found in the homeless population. And so as we think about closing these gaps, we have a lot of work to do, because these extreme impacts of policies and access and outreach are having a very disastrous effect within the Black community in particular, but disproportionately among all people of color. You can go to the next slide. Okay. So it's no surprise then that the housing strategies that are pursued by CountyCare and Cook County Health are really actually lodged within the Office of Equity and Inclusion, and that the county is taking a multi-layered approach and holistic approach to really provide an equity response to the needs of members and patients experiencing homelessness and at risk of homelessness. And as we look across these different initiatives, having this view of all the different touches that the health plan is taking, this allows the health plan to really thread consistent themes and test solutions to advance these larger changes. So if we think about the flexible housing pool that both Jessica and Michael will talk about later, it's a housing strategy with a housing and services strategy. But these are also areas that can be pursued in policy. It's a strategy that's uplifted in the Advancing Health Equity Learning Collaborative and looking at how to make components of the flexible housing pool model to be covered as covered services through Medicaid, through something like housing tenancy supports and conducting that advocacy. And that it is data driven, able to look at it from an equity approach as well. Next slide. So one of the strategies is around recuperative care. And so I'm just going to give a very brief overview, and I'm sure many of you know quite a lot about medical respite care. But one of the innovations that the health plan and Cook County Health have pursued is to provide an add-on to the census of medical respite and highlighting the Medical Respite Center in Oak Park. It's a post-acute care for people experiencing homelessness. Respite care can have a medical approach, a social approach, or a combined medical social approach. And so we have a number of those across Illinois that take different approaches to providing respite care. And you can read more about these standards of practice at the link in this slide. So organizations like the Boulevard may have both a social and medical approach, whereas a DuPage PADS has really just a social services approach to providing ongoing care and housing options for people experiencing homelessness being just discharged from the hospital. So the Boulevard has on-site medical staff and partnership with some capacity for post-hospital care, and DuPage PADS, for instance, is a separate, more private hotel accommodation, but cannot provide any clinical medical care support. So that is something to look for in pursuing additional medical respite opportunities. One factor to expanding respite care is to understand the role of payment and how to cover the costs for the beds, and that can happen in different configurations. So in California, for instance, they have successfully gotten the state Medicaid to identify medical respite as an in lieu of service, where it is authorized for managed care to cover. It's not required for people to receive. It's a medically appropriate and cost-effective substitute for another service or another setting that is covered under a plan. So we know that oftentimes nursing homes are used for discharge from hospital care because there is no respite, whereas respite may be more appropriate, and a nursing home stay is the thing that's most available. So that may be something for this group to consider as to how Illinois can advance that concept. Next slide. Okay, the medical respite in Oak Park is 19 beds and has been up and running for not quite a year. So for the data that I have to share is through July of 2021, and that during the December to July, 95 individuals were referred and 64 were enrolled. 45 completed the full clinical stay. So this location is a partnership between Cook County Health and Housing Forward, where Housing Forward provides the housing management, and then there is an interim housing program also co-located in the building. Of the 64 enrolled, 13 were uninsured, and the remainder were spread across 8 health plans, with the majority being from CountyCare. For the 45 people, or for the 64 people who were served, 45 completed fully the medical clinical stay. 13% left for stable housing. So the vast majority continue to experience homelessness or have moved on to temporary housing. 40% went directly into other homeless programs. So when we consider continuity of care and to prevent future recurrence of a medical need, there is an opportunity to leverage additional stable and permanent housing for people when they exit medical respite. Next slide. Okay, sorry, I'm having a little bit of a delay. And so when we think of the, as you can see here is the MRC eligibility, and it is more of a clinical model and having tighter clinical criteria to enter that may be less so at another program like the Boulevard. When we think of this, the data show that over half of the patients that were served received care for post-procedure and pathological wound, and the next level being COVID isolation. So while there are 5 clinical criteria and residents of the MRC did experience all of these, including end-of-life care, 78% were served, were referred specifically due to post-procedural care and COVID isolation. Next slide. So that concludes the introduction to this section. I'm going to pass it off to Jessica.
Good afternoon, Jessica Chapman with CountyCare, the health plan. I am going to talk about how the health plan utilized data to target housing interventions for members experiencing homelessness. And first want to just level set with the next slide. And talk a little bit about the challenges that we see in terms of patients as they go through this cycle of various high cost settings, which is really continuous and ongoing. And when we think about housing plus or housing as an healthcare intervention, we know that we want to interrupt this cycle and ultimately address the presenting needs of the member, one of them being housing, and really focusing on identifying safe, stable, permanent housing for members, in addition to the medical needs as the health plan. You can go to the next slide. So I'm going to talk about data as it relates specifically to the Flexible Housing Pool program, which is an initiative that CountyCare has directly invested into. And this program is a supportive housing program. So it includes 2 components, one being the actual brick and mortar, so the permanent housing placement, as well as housing tenancy support. So housing case managers that are assigned to work with members as they're enrolled in the program and assist them through their housing journey. This program is looking to rapidly house individuals who are literally homeless, and it includes both individuals and families. The Flexible Housing Pool is a partnership between healthcare, government entities, and homeless service providers. And so within Cook County, we have Cook County Health and CountyCare, the City of Chicago, Chicago Housing Authority, and Housing Authority of Cook County in terms of the overall partnerships. And the Flexible Housing Pool program is funded through a mix of public and private investors. Many managed care plans, such as as CountyCare and others, have directly invested into this program. And the program is administered via the Centers of Housing and Health, and they also have subcontractors that do some of the outreach work to identify members who are found eligible, as well as the housing case managers. Next slide. So in terms of the flexible housing pool and their organizations that are currently providing housing case management and outreach services, this is a list of those organizations. And we will actually hear from Renaissance later in the presentation today. But you can see that these organizations are experts in terms of navigating the housing field and assisting members, ultimately, getting them permanent housing. They provide case management services as well as able to support both youth and adults in Chicago and suburban Cook. Next slide. So in terms of the flexible housing pool program eligibility and data, the eligible members are identified through the Flexible Housing Pools program evaluator, and he combined data from the Homeless Management Information System as well as utilization data in order to identify the program baseline eligibility criteria. And two of those points are persons who are literally homeless or unstably housed at the time, and also persistent utilizers of services. And this is a unique definition defined by the program evaluator. And it really looks at over time, is the person likely to have either emergency department visits, jail encounters, and or homeless service utilization. And so if we look at this first outer circle, persons experiencing homelessness, so this is the entire, I guess, population, we would call it, in terms of FHP eligibility. And these are people who are registered in the Housing Management Information System. And then as we move into this first inner circle, the light blue color, this is the evaluator has applied the persistent utilizer criteria, which then brings, which would include people who are likely to utilize the ED system, as well as the jail and also the homeless information system. And then if we continue to move into the circle, now we have identified the CountyCare target group. So this would be all CountyCare eligible members who meet the program baseline criteria. And what we did here was simply apply the health plan eligibility. So these would be members who are eligible for CountyCare. And then as we continue to move into the inner circle, we get into how we prioritize outreach efforts for this larger group. And that included members who have a behavioral health condition, as well as children who are a part of families experiencing homelessness. And this very inner circle, the very dark purple here, is just a subset of the priority group. And it includes further prioritization for members who were identified as high utilizers and also high cost. We go to the next slide. So in terms of how we kind of filter down the data to identify the CountyCare members who are eligible for the flexible housing pool, as well as prioritize them for outreach, do want to note that this data is from 2019 and it is the original data from the program. And so it's been broken down into 4 population groups. So if, as we kind of walk through the first group here, again, this included the HMIS data, so the Housing Management Information System, both City of Chicago and suburban data, and there was 600 people registered in that system. And then as we continue to work down, we identified CountyCare members or Cook County Health patients with utilization between April 1st of 2018 through March 1st of 2020. We utilized claims data for this, and the population identified was 482 members at that time. And then as of October 1st of 2020, of that group there was 349 members who had active CountyCare eligibility at that time. And then from that population, CountyCare members with the additional claims history left us with 244 members into 4 groups that I kind of spoke about earlier, but they were children that were a part of families experiencing homelessness. There were also single adults in Chicago with a behavioral health condition, and this included both mental health and substance use disorder. And then we looked at those same criteria for suburban Cook. Next slide. So in terms of just some high level takeaways in regards to the data for Flexible Housing Pool program, and do just want to note that while the data that we referenced today is the original data from the program launch, we continue to receive updated eligibility and claims data monthly for the overall target group. So that would be for the entire population, and that's how we continue to prioritize members for outreach. And do just want to note that the top conditions for that particular cohort were diabetes, asthma, hypertension, and obesity. 75% of CountyCare members from that original target group are currently still eligible, and this was as of August of 2021. And then 64% of members from the overall target group had utilized the emergency department or were admitted during February of 2020 through January of 2021. And then the top 10% of Flexible Housing Pool members does make up about 50% of the emergency department and inpatient visits. Next slide. All right, I am going to pivot to talking about care management and housing as a healthcare and intervention. And so in terms of our care management program related to housing, we do have oversight. So there are standing agenda items related to the Flexible Housing Pool and housing initiatives at our monthly joint operating meetings with our various care management teams. And these meetings include all of our care management team program leaders. And so they are part of those conversations, and we're tracking initiatives very closely as it relates to member outcomes. And additionally, in terms of housing, we have built out program policy and procedures specific to housing initiatives, and also resource guides related to the various housing initiatives to help our care management teams navigate the housing landscape to better assist members who are experiencing homelessness. Additionally, we have identified housing liaisons within each of our care management entities. And we also have a dedicated Flexible Housing Pool program coordinator who is our liaison with the Flexible Housing Pool and their subcontractors in terms of, she's really close to the member level data and just the experience that our members are having as it relates to enrollment into the Flexible Housing Pool program. And additionally, the key areas for our care management program as it relates to housing initiatives is adopting this the mindset that, you know, the CountyCare model is looking at housing plus care management as a health intervention. While we know that housing is not a Medicaid covered benefit, when we kind of think back on that cycle and some of the kind of glaring statistics that Betsy shared with us, we know that this is an area of priority for CountyCare, and we do know that by doing that, ultimately members will receive safe and stable housing, as well as be able to focus on their health and other goals that they have for themselves, and have better quality of life. And then from the health plan perspective, we are also able to kind of see some improved outcomes for members. Also, just want to note that our care management program really considers any member experiencing homelessness as at risk, and we do make it a priority to offer them care management services and enroll them into our complex care management program, and develop individualized care plans with them that include housing as a goal, as well as our care management teams do focus on collaboration with the various housing partners. Next slide. So just want to point out here, in terms of our care coordination teams, they are really just highlighting that, again, all members experiencing homelessness in the flexible housing pool are offered care coordination services, and that the care coordinator is the point of contact for the member. And I know that many of you on this call are very familiar with care coordination services within the managed care plans. But as it relates to housing, we want to just focus on the integrated care team, as well as the relationship building with members of the ICT. And we'll kind of talk about that in the next slide, I believe. And in terms of our care coordination resources, so we do know that the point of contact, and I'm referring to our flexible housing pool coordinator in terms of how she interfaces with the care coordination teams. So she is the point of contact for providers, working directly with members, responsible for ensuring members' consents are in place, as well as the focus here is going to be on the integrated care team as well, including bidirectional information sharing and coordination of members' care across the various providers and housing organizations. Next slide. So now we are looking at, the CountyCare model in terms of the integrated care team, which is a diverse group of individuals and professionals who provide support and oversight of the members' needs and ultimately help them achieve their healthcare goals. And so the member is at the center of this team. The member is at the center of this team and is a part of identifying who is a part of their integrated care team, including any preferences of providers and any additional healthcare preferences related to who the member has on their team. But we do know that at the CountyCare health plan, we have integrated our housing staff, so that includes housing case manager, which is an example listed here specific to the flexible housing pool, would be a part of the integrated care team, and information sharing is occurring within this model. Just want to say that this example is just noting the flexible housing pool, but there are various housing programs that many of our CountyCare members receive services from. And so the overall model here is really that the housing providers are a part of the integrated care team as we look at housing as a healthcare intervention. Next slide. So I do want to take a moment to talk about systems integration team. And this is a specific group of people and meeting related to the flexible housing pool. And I have inserted from the Centers of Housing and Health, who administers the flexible housing pool, their definition around the system integration team, which is really about efficient communication, about participants in the program. And so it is an interdisciplinary team. It is representative of, healthcare providers. The flexible housing pool program manager is a part of those meetings. The outreach workers that are closest to the street work in terms of street outreach and finding members that are eligible. It includes the housing specialists, landlord engagement specialists, and also additional program specialists and housing case managers are included in these meetings. And as you can see, the housing landscape, it includes many people are involved when we think about a person who is on their housing journey to safe and stable permanent housing. And so this setting really allows for these everyone at the table to communicate to make sure that the best plan is in place for the member, addressing any barriers related to ultimately housing the member. And this meeting is occurring regularly within the flexible housing pool, and CountyCare does participate in these meetings as well. And in terms of how CountyCare collaborates with SIT, or Systems Integration Team. So again, I noted that we do have a dedicated resource who is the Flexible Housing Pool Coordinator. She is our liaison and point of contact. She is coordinating any linkages and including the assigned members care coordinator, also providing case consultation for members who need additional support. And in this setting, we have also provided education and resources offered by CountyCare to members, as well as done a presentation around, navigating managed care and eligibility into Medicaid for the SIT meeting. Next slide. In terms of additional support at the health plan. So in addition to our care management teams, we have also partnered with our utilization management team in terms specifically for the flexible housing pool members. And so the way that we do that is there is a monthly list shared with our team for tracking. So within our utilization management system, all flexible housing pool members are flagged. And so if you go into the system, you can clearly see this is a FHP member or this is a member experiencing homelessness. So that indicator is clear on the members page in the system, which allows us to track easily. But in addition, our team is looking at this list regularly. They are notifying our flexible housing pool coordinator and care management teams when a member who is in outreach or in the program connects to healthcare. So that could be any activity, including inpatient hospitalization as well. And then in terms of the transition here, so there is a real-time notification that is occurring from our team to our flexible housing pool coordinator, which allows us to outreach members in real time. Next slide. All right, I am going to pass it over to Michael.
Thank you so much. Thank you so much. So thank you for having me today. I'm going to talk a little bit about the role of Renaissance in working with the flexible housing pool. For those of you who don't know, Renaissance, we're an organization we've been around for 24 years now. we work in communities to help people with housing, behavioral health care, street outreach, homeless prevention, and a focus on racial equity to really support people within the community to achieve stability and wellness. Next slide, please. We have programs that go all the way from street outreach, including the flexible housing pool, to crisis prevention and diversion. We have a living room program that we have in the Austin community. Homeless diversion and prevention to try and keep people from entering the homeless system. A rapid rehousing program through Expedited Housing Initiative, permanent supportive housing across the city for both singles and families, senior housing, and then we work with developers as well to help foster the creation of more affordable housing in Chicago as a whole. Our behavioral health programs are CARF International accredited for both singles and families. Next slide, please. So Renaissance was part of the Better Housing for Health Collaborative, which is kind of the precursor to the flexible housing pool. Better Health Through Housing Collaborative started in 2013. It was an alliance of 28 organizations across Cook County who were really focused on trying to bridge the gap between the housing and healthcare sectors. And then the Center for Housing and Health was selected as the lead agency and the convener for this Better Health Through Housing project. Then in 2015, the first contract, we got the first contract with University of Illinois Health and Hospital Systems and to provide per member per month payment to the collaborative in order for us to serve high utilizers of their emergency department with permanent supportive housing and services, right? And originally there were 3 of us organizations, permanent supportive housing organizations, who were doing that. And one of the outcomes of that initial collaboration, the Better Health Through Housing, was that UI Health and Hospital Systems saw a decline of about 67% in their emergency department use in that first year. So they decided to reinvest, and then other investors came on and we morphed into the flexible housing pool. So when the flexible housing pool became its own thing, the Center for Housing and Health decided they wanted to contract with Renaissance to provide the street outreach for the program, and then asked if we would also be able to provide some of the case management as well. So I'll talk a little bit more about this later, but we're also working to create some additional support and services for the flexible housing pool program, creating a new community support team for people with high needs and behavioral health diagnosis. And so we're really going to be targeting participants who need additional services in order to achieve the stability. And ultimately, we're looking to see how we can fund this through Medicaid. So the idea, okay, next slide, please. Yeah. So the idea really is, providing, I'll talk about that in a minute, in the case management. So the outreach that we do, we take referrals from the Center for Housing and Health, who coordinates those referrals from the different organizations who are contracted, including CountyCare. With CountyCare, if the referrals coming from the emergency department, then we have a protocol where we go and see the person right away. So in order to really be able to get to the person when they need it the most, as a high utilizer, typically they're coming in and out of the emergency departments, and the best time to get them is when they're there. So what we'll do is the outreach team will then go to the emergency department and meet with the person there and begin the process of getting them housed in bridge housing, which is housing where the person can stay for a short period of time, and it's housing we can get them in like today, right? We could get them into housing if they show up at the emergency room, get them housed, and then get them ready to move into a permanent housing slot where they'll have a lease, and then the services will be provided by ongoing permanent supportive housing provider, right? So, and I'm not sure, Christine Haley was going to talk a little bit about some of the warm handoff that we do, a good example. I'm not sure if she's with us. Christine?
She's not, Michael.
She's not, okay, yeah. All right, well, so the warm handoff is the important part of it. And if we're not able to engage with people at the emergency department, then having a warm handoff between the provider and the outreach team is really important because it creates it helps avoid the idea of a person falling through the cracks. So if you're able to get connect with the person right at the time where they're receiving some other services, some other emergency services, or they've showed up and really they don't need crisis care. What they need is they have a cold, right, or they need a warm place to stay for the night. Then it's easier then for us to engage with them and say, well, we can provide you with a warm place to stay on an ongoing basis, right? They've already been identified and flagged as a high utilizer, and so then we work to get them very quickly into the bridge housing, right? So the flexible housing pool, since the program started, we have served over 550 people, and last year being 2020, we engaged with 179 people, and this year we've really kicked it up. We've hired additional staff, and we have engaged with 371 people. Next slide, please. So then the goal is to really have a warm handoff to the housing case management. So once we get them into the bridge housing and we're starting to get them prepared to move into permanent supportive housing or just permanent housing, we'll work with the case management at the PSH program or at the or another provider who's going to be working with them on an ongoing basis to do meetings together, right? So we'll help the outreach staff will work with them after they're placed into permanent housing, after they move in, and continue to meet with them together with their new case managers in order for them to develop that relationship with the new provider as well, right? So the case management, So some of the outcomes I wanted to provide to give you an idea about what we're seeing in terms of the time to housing. So the goal is less than 30 days. Sometimes it takes longer, of course, because people don't have documents or there's backgrounds. For our adult cohort, the median days to housing in our most recent evaluation of this was 159 days. Some of that was COVID related, and for the youth it was 63 days. So it was a lot. It was less for the youth. We're really trying to focus on getting that lower and lower, and as things with COVID are opening up, I think we're doing a better job in getting people housed in a much faster method. So the case management that is provided then is about a 20-to-1 caseloads, helping the person, get stable in their new housing, increasing their income, and getting the healthcare, the behavioral healthcare they need, and then the self-management skills. I think most of us know what sort of case management is. One of the biggest challenges that we face, and which is why we are talking about having creating a CST team, is that because the population served in the flexible housing pool really are disconnected from the system, the healthcare system, the behavioral health system, because they've had negative experiences, because they don't feel like they can trust the healthcare system, which is why they end up being high utilizers of the emergency department instead of primary healthcare. So we're having to spend, for some people, a lot more time kind of holding their hand in the initial process of helping them get the primary healthcare and understand that they can trust the doctors and the nurses there in order to get the care that they want. And for the people with the behavioral health disorders, it makes it especially challenging. And so we're looking at creating a CST team in order to really have the more intense services that come along with that, lower caseload sizes, and the more focus on the behavioral health issue when we work with them. Next slide, please. So we're looking to, we've started to move people on from the flexible housing pool, and thank you, I know I went ahead. And we're getting some people to graduate as they become stable and they've engaged with healthcare. And the outcomes that we're seeing are some significant cost savings to the healthcare programs and to the care agencies and the insurance providers. And we're seeing some significant stability on the part of individuals as well. Last year, we had 97% of the population who is part of the flexible housing pool who remained stable during the whole year, during the entire 12-month period. So it was a very small percentage who were not remaining stable. Thank you.
So in conclusion, I hope you all understand, as we've depicted today, the importance of providing housing to our members who are experiencing homelessness, how we target the populations that we aim to house, that being the most vulnerable, and the role that care management plays not only in the housing process, but in building relationships and changing those trajectories. And lastly, that street outreach and bridge housing are necessary components in the strategy so we don't lose our members. I'd like to thank my speakers today, Betsy, Jessica, and Michael. And of course, I'd like to thank IAMHP, and we are happy to take any questions.
Dr. Collins and all of our panelists, I am in awe of all that you do, your innovative thinking, the way you have really taken this idea and just run with it and at the benefit of the members and the communities here in Illinois. And so I am so appreciative for all that you do. With that, it is so hard to summarize. I can't believe, Dr. Collins, you've got the conclusion down to 4 bullet points because there was so much covered in that. That being said, I'm so appreciative of the work, but putting the member at the center, as you walked through the care coordination and as you walked through all of the different components, what I really heard is that human element to the story. These aren't just numbers, these aren't just algorithms or things, these are true people, and they felt very seen throughout this process. And so I'm really appreciative of all that you do. As a reminder to all of those who are viewing this live, we will be posting this video on our YouTube, but we will also be sending it out along to all of our registrants. That being said, there were a few different links that were referenced as we moved along this presentation. Those have been submitted in the chat for those of you who are viewing this live. For those of you who have received this in an email, it's also included in the email. And for those of you who are viewing this on YouTube, it's included in the below the video for you to reference. With that, unfortunately, panelists, we are just run out of time and we don't have time for a Q&A, but I know that these conversations can and should be continuing. So feel free to reach out to our panelists today should you have any additional questions. And I hope that this starts a conversations between you and your colleagues as well, not only about what's happening and what's on the ground, but where we can take this and how we can grow this. And so thank you again to all of our panelists, but all of you who took this time out of your day to learn more about what's happening in Medicaid managed care here in Illinois, in county care with our providers, and what's happening within the housing community. With that, stay well and stay healthy. Have a good one. Goodbye.
Thank you, Alaina. Always a pleasure.